Hey everybody, Will Martin here. I've got a paper that I came across yesterday on Science Daily having to do with emergency departments, and so I clicked on it. I want to share it with you here and tell me what you think. On Science Daily, it was titled How to Keep People Out of the Emergency Room. And these are findings from a New York City program that helped arrange medical appointments for undocumented immigrants with limited incomes. And the data was collected between May 2016 and June 2017. Now, those who received assistance in scheduling visits with PCPs experienced a 21% drop in ED use. And for individuals with high risk medical profiles, I'm assuming like hypertension, diabetes, that sort of thing, and they received the same help, the ED visit use dropped by 42%. So, not bad, not bad at all. The authors say that it had the biggest impact on those who were the most ill. Lowering the barriers to care for those in need individuals really pays off in terms of keeping them out of the ED. So, if that's true, that's great. Let's read on. So, the actual name of the study, the paper was called Reducing Frictions in Healthcare Access, the Action Health NYC Experiment for Undocumented Immigrants. And it appeared in the September issue of the journal American Economic Review. The co-authors are professors. They're not primary care providers. They're not healthcare providers in any way, but they are professors of health policy, professors of economics, Global School of Public Health, and the final author was the executive director of Healthcare Access and Policy in the New York City Department of Health and Mental Hygiene. Okay, so the experiment had more than 2,400 participants with almost 1,300 in a treatment group, and these people received help setting up a primary care appointment. Another 1,100 participants served as a control group and did not get the same help. Everyone in the program had a household income no greater than twice the federal poverty line. The program reached people by partnering with community-based groups, mailings, social media, and buying TV and print media ads. Okay. The effect of the program was rapid, according to the authors. In its first 3 months, 57% of people in the treatment group visited a primary care physician, while just 16% of people in the control group did the same. Those in the treatment group saw a savings of just over $195 in ED visit costs, which rose to over $477 for the higher risk patients. And just a reminder that federal law requires emergency departments to not turn away patients. Okay, so a question that I have is that they keep mentioning primary care physicians. I wonder, I don't know how many people actually saw primary care physicians. You have to wonder, because I know in New York City, there's a large presence of nurse practitioners and PAs providing primary care in the city itself, in the city proper. But the program did all of this without extending health insurance to anybody. Most visits had a $15 copay. Many of New York City's public health institutions scale costs to the patient's ability to pay. The aim of the program was to see what difference it would make, insurance aside, to help nudge people to see a doctor in the first place. All right, good idea. I thought that there was a decent chance this program wouldn't have much of an impact, according to one of the authors. The fact that we could find such a big effect was surprising to me, and I think it illustrates the non-financial barriers that people are facing to get the care they need and the role of management in that. Okay, I think that's probably the most important point of this whole paper, is that it's not a financial thing why people don't get into primary care. So let me just stop and talk about this. In my experience, I will see a patient in the emergency department. Let's say they come in with high blood pressure. Let's say that it's not high blood pressure that requires hospitalization, but maybe they've never been on a blood pressure medicine, or maybe they were a long time ago. They need to get restarted on it. In some cases, after we check for any signs of end organ damage, checking a creatinine, getting an EKG, making sure that they don't have diabetes, that sort of thing. If we can really assure ourselves that they don't have any signs of like renal failure, that sort of thing, we'll put them on maybe a low dose lisinopril or amlodipine, something like that. And then the key is we need to get them seen in primary care, within a couple of weeks would be great. That's where the problem lies, because I'll discharge that person and then they never follow up with primary care. And why is that? That's the thing that needs to be studied. Do they not follow up their primary care because they figure, well, I got a prescription for, 2 weeks or 4 weeks of blood pressure medicine, and maybe I don't really need it anyway. I don't know. Or maybe it's a child care issue. It's hard to say, but we started a program in our hospital recently. It's called Connect Care, and it allows me to make a phone call on behalf of the patient and get them seen by usually a nurse practitioner in our hospital within 24 to 48 hours of ED discharge. And it's great because it allows me to get them in to see somebody, but then that's not going to be their primary care provider. That's another middleman. It's a great idea. How many people actually go to it? I don't have data on that. But again, once they leave the emergency department, I have no idea whether they're going to follow through or not. And I think that's the bigger question here. Separately, as the authors note in the paper, extending formal health insurance to undocumented immigrants remains politically untenable for the most part. On the other hand, jurisdictions might examine if other approaches increase care while, in this case, lowering emergency room traffic. Okay. Again, you can give somebody health insurance, but for 100 other reasons, they're not going to make a primary care appointment. Or the other thing that I think is that they may want to try to get a primary care appointment and they can't. Because in my experience, a lot of folks will come in and say, all right, I do have a primary care doctor. I called, it's September 1st right now, but the first time that they'll be able to see me is December 15th. So what are they going to do? They're going to have to come to the emergency department. So it's really, there's a gap in primary care. And I think if you want to blame one thing for the emergency department overcrowding, it's the lack of primary care. And, we can talk about that a little bit more later on. There's a tendency with healthcare to think that if you give people health insurance, you're done. The study is saying the right system combines insurance as financial protection with other kinds of tools. There's just a huge potential to use data and science to get people to where they need to be in terms of getting the most efficient care. So, what they're saying is you can give them health insurance. Doesn't mean they're going to use it. You've still got to get them incentivized somehow to go see a PCP. And how do you incentivize somebody to go do that? I mean, unless they're actually feeling ill. And if they're actually feeling ill, if they're having belly pain or something, they're going to call their PCP, and maybe best case scenario, that PCP is going to say, I can see you day after tomorrow. And that's not going to work, and understandably so. There's a lot of things that could be going on. Those folks wind up coming to the emergency department anyway. So I think what we need to really do is strengthen our primary care focus. And I won't get into it right now, but nurse practitioners were supposed to be the primary care providers, but we all went into other specialties very quickly after graduating. And it's just the way it is. That's the way the market has used PAs and NPs. But anyway, all right, I'll stop rambling right now. Just wanted to share that with you, and hope to see you on the next video. Okay? Thanks. Bye.